had very interesting presentations in this session. Thanks to Dr. Azad's vision about this session, I must say, and very relevant to the current scenario where we are all deciding what agent to use. We are restricted by administrative and government norms, safety issues. So I've been fortunate enough to have tried Aflibercept in a large number of my cases, because maybe we are doing more frequent ICG, and in any suspicious case of CNVM we do it, and we've been finding in our series at our center, out of the referred patients, nearly 50 to 55% patients having some element of polypoidal choroidal vasculopathy. So we are dealing with a drug which is more of a pan anti-VEGF rather than just targeting VEGF. It works on it works on both sides of the VEGF dimer, and it has shown a proven supremacy in its suppression of VEGF. It has also shown longer time for CNV recurrence to take place after treatment. So in nutshell, it is a cost effective by reducing direct non-medical costs, where we are dealing with fewer number of injections. And this is the view 1 extension, which shows visual acuity gains were sustained to week 212 with modified quarterly Aflibercept dosing. And so proactive regimen and its potential to reduce the number of injections and the treatment burden is what we all are trying to focus on. A proactive treat and extend regimen with reduced number of visits should make it easier for patients to manage travel to and from the clinic, lesser visits, lesser burden to the patient and the family, help ease some of the burden on the clinic and improve clinic flow, and also provide reassurance that treatment, if delayed, will help to alleviate the stress experienced by some patients about treatment delays because of various issues like insurance clearance, etc. So TREX showed us that ranibizumab treat and extend achieves similar outcomes to monthly ranibizumab in 2 years, with a mean of about 18.6 injections even when treat and extend was followed. And it was quite similar to monthly regimen. Aflibercept, around 50% of patients were maintained with quarterly or less frequent dosing beyond year 1. One of my cases shows you a case. In the initial ICG we didn't pick up the polyp, but in the later ICG we picked up the polyp post-treatment. We repeat the ICG normally after 3 months, and you see this polypoidal area highlighted, though there was some evidence here in the initial OCT. For Aflibercept over 1 year, only eyed patient, visual acuity 6.9. Patient is on a treat and extend regimen, and though looking at Dr. Giridhar's presentation, we have not used Avastin for the last 5 years. I'm tempted to restart using it now in these cases and further reduce. Another patient who had only eyed, senior lawyer who had undergone right eye PDT, eye was scarred, counting finger vision, left eye 2 PDTs and 6.9 vision, this huge branching vascular network which you see with a high potential of developing sudden submacular hemorrhage and losing all potential of vision. Initiated his therapy in January 2016. We are nearly completing 5 years now of Eylea therapy in our patients. I think since the 4.5 years since its introduction into India. And there was a little setback here in March 2017. Otherwise, he was maintaining a vision of 6.9 with repeated therapy, and he's taking about 2 to 3 injections a year now. He maintains in 2000 December 6/9 vision with this clinical picture. I think it's a very gratifying result in an only-eyed patient where we are looking at the potential risk of a sudden submacular hemorrhage and total loss of vision. We all have operated, we all have seen such cases. So 42 to 50% patients in Altair of patients extended to 12 weeks and beyond at their last interval beyond 52 weeks. And the data has been from other studies also. So a pragmatic, practical approach, I would say, when you do OCT and you find features suggestive of PCV, go ahead, do an ICG, positive features on ICG, which is in a large number of cases, as Dr. Giridhar would also testify. I think he has the largest series in the country on PCV. Initiate Aflibercept therapy, load 3 doses and treat and extend on a quarterly basis. So we are entering a era of new pathology of Aflibercept in neovascular AMD reflects its suitability for proactive treat and extend regimen, allowing extension of treatment intervals in 2 to 4 weekly increments in year 1. And we offer our patients the best possible costing for Aflibercept. If they are on long-term treatment, we just do it on an injection basis. We don't even charge anything for the services. And I know it's off the record, I can't say on a podium, but we don't hesitate if we have 2 patients in sharing the injection, because the doses is enough for 2 patients and cut down the cost further for the patient. Thank you very much, Dr. Azad and everybody, for this opportunity.
Thank you so much.